Hi everyone, my name is Anila Mitchell, and today I'm going to be presenting my capstone project about preeclampsia rates in the United States, and specifically about how Black women disproportionately experience these rates. Preeclampsia rates affect about millions of women each year. However, the burden isn't shared equally. Black women are diagnosed with preeclampsia double the rate as white women, experiencing 6 to 12% in comparison to 3 to 5%. Across multiple studies that I have reviewed during my project, I have noticed that Black women experience delays in diagnosis, less symptom recognition by providers, and lower rates of treatment, which can all contribute to higher rates of preeclampsia. This is a very important topic because it shows that these disparities are not only due to biological differences, but it's rooted in systemic racism in healthcare. Factors such as provider bias, Medicaid insurance coverage, and access to quality prenatal care are all examples of socioeconomic factors that contribute to higher rates of preeclampsia seen in Black women. Several studies are also shown that Black women are less likely to be offered treatment for preeclampsia, such as low-dose aspirin, which has been scientifically proven to reduce the rates and symptoms experienced of preeclampsia. Even when Black women show a high risk for preeclampsia, they are still often denied this access to low-dose aspirin. Delays in recognizing these symptoms, combined with inconsistent follow-up and insurance barriers, this creates a larger disparity gap seen in maternal mortality and morbidity, and when we're looking at Black women versus white women. To further explore this issue, I conducted a secondary cohort analysis and comprehensive literature review. I used peer-reviewed articles ranging over the past 10 to 15 years. Some of the search terms that I used were preeclampsia, racial bias, maternal outcomes, and Medicaid prenatal care, or just Medicaid in general. I reviewed primary and secondary studies to understand the diagnostic and treatment disparities. Then I used tertiary studies to identify policy reform and interventions that could possibly help the Black communities. Across all studies conducted, I saw several consistent patterns. Black women are more likely to experience frequent dismissal of symptoms, which can lead to a delayed diagnosis. Black women were also less likely to receive aspirin treatments even though they were eligible to have this intervention. One study showed that Black women who were eligible for intervention received 20% less likely chances of actually receiving this low-dose aspirin that could help manage their preeclampsia symptoms. Additionally, this is very important to note that several studies found that the diagnostic criteria for preeclampsia was centered around white communities, which made it less sensitive to Black communities. This means that the early signs of preeclampsia aren't always caught in Black and even other minority communities. I created this policy briefing to reach Medicaid policymakers, state maternal health organizations, and hospital administrators. My goal was to take complex research and turn it into clear, achievable policy solutions. Realistic solutions that I would propose includes expanding Medicaid-friendly resources such as community health workers, doulas, and transportation services within these communities. Ensure that there are flexible providers that may even offer telehealth for prenatal access. Mandatory implicit bias training for all maternal health care providers that's tied to licensure or hospital credentials. Expanding coverage for Medicaid-friendly resources, prenatal resources, can strengthen early access to prenatal care and create a positive environment for all mothers. The call to action that I am proposing is realistic and actionable, and can meaningfully reduce the racial gap seen in preeclampsia outcomes. Black women deserve safe pregnancies, access to prenatal care, and equitable care overall. By reforming Medicaid policies and enforcing bias training, we ensure accountability for all healthcare providers. We can ensure a future where maternal outcomes are equitable, not based by race, but for everyone. Again, my name is Anila Mitchell, and thank you so much for listening.